Heart failure is not simply a weak heart. It's a complex interaction between the heart, nervous system, kidneys, and blood vessels. To understand why patients with heart failure initially survive and later deteriorate, we need to understand the circulatory dynamics that occur immediately after the heart begins to fail. Imagine a patient who suffers an acute MI. Suddenly, a portion of the myocardium loses its ability to contract effectively. As a result, stroke volume falls, and because cardiac output is the product of heart rate and stroke volume, the overall cardiac output decreases. The immediate consequence is reduced blood pressure and inadequate tissue perfusion. Vital organs receive less oxygenated blood. The patient becomes weak, dizzy, cold, and shortness of breath. And if the left ventricle is affected, blood begins backing up into the pulmonary circulation, increasing pulmonary venous pressure and eventually leading to pulmonary edema. If the right ventricle fails, blood backs up into the systemic venous circulation, producing raised JVP, hepatomegaly, peripheral edema, and later ascites. Fortunately, the body does not remain passive. Within seconds, baroreceptors in the carotid sinus and aortic arch detect the sudden fall in arterial pressure and activate the sympathetic nervous system. This response is designed to preserve perfusion to vital organs. Heart rate increases, myocardial contractility improves in the surviving muscle fibers, and widespread vasoconstriction redirects blood away from less essential organs such as the skin and gastrointestinal tract toward the heart and brain. This is why patients with acute heart failure are often tachycardic, sweaty, pale, and have cold extremities. These compensatory mechanisms partially restore blood pressure and cardiac output, but they cannot completely overcome the mechanical loss of functioning myocardium. As hours pass, another powerful compensatory system begins to dominate. Because the kidneys receive less blood flow, they mistakenly interpret the reduced perfusion as dehydration. In response, they activate the renin-angiotensin-aldosterone system, while antidiuretic hormone secretion also increases. Together, these hormonal pathways promote sodium and water retention, gradually increasing blood volume over the next several hours and days. At first, this response is actually beneficial. The increased circulatory blood volume raises venous return, increasing ventricular preload. Through the Frank-Starling mechanism, the cardiac muscle fibers are stretched to a more optimal length, allowing the damaged heart to generate a stronger contraction and eject a greater stroke volume. In patients with moderate heart failure, this additional preload can improve cardiac output sufficiently to maintain adequate organ perfusion despite reduced myocardial function.